Hi, everybody, and welcome to a special episode of the EMS Today Show. I'm AJ Heitman, and I'm really pleased today to have a panel of 5 experts in the field. What I'm calling this particular session is the true COVID-19 first responders, the emergency medical dispatchers, and Protocol 36. And quite frankly, I've been rather pissed off that I haven't heard the task force or anybody else really talking about the dispatch center. I think until it's all said and done, we're going to find a lot of our stress is going to be coming from the dispatch center. When I started out as a youngin' in the field running an EMS system in Pennsylvania, I went through the emergency medical dispatch program, and I thought it was very detailed, very important to have. And I didn't even have a center that was dispatching. I just had a center that was working with dispatchers throughout the region. And then when I look at Protocol 36, today, it really probably is about the same length of the whole program that I went through many, many moons ago, back when we were still using horse and buggy. So, and then when I came to GEMS, one of the things that I began to realize is that GEMS was one of the first places that really recognized Jeff Clausen and the emergency medical dispatch system. And it was really foreign to people at the time. And I'm going to tell you, I think that many of you will walk away from listening today and realizing how foreign Protocol 36 has been to you, and realize that the dispatchers are really out there to save our butt, that they are our true front line, trying to triage calls and to do it in the appropriate way. And what I understood from talking to Dr. Clausen the other day, something I totally forgot, is every time somebody makes a change to a protocol, it has to be changed in, and you guys will tell me the number of languages, but that's a phenomenal. So my hat's off, not just to the dispatchers, but to the staff of the emergency medical dispatch. So let me give you a quick overview of the caliber of our folks here. I'm not going to spend too much time, but it's really important that you understand that if you go back to the website, if you go to anything else regarding a protocol change, you understand the depth of the professionalism. Jeff Clausen is the chair of the rules group of the Medical Council of Standards of the International Academies of Emergency Dispatch, IED, and medical director of the IED Research Standards and Academics Division. He's also the CEO, lead scientist at Priority Dispatch Corp, and that's a full load, boy. And you've been doing that for how many years, Jeff?
Well, since 87.
87. That's quite a long time. As the inventor of the Medical Priority Dispatch Center, widely recognized really as a standard of medical dispatch in practice, you're often referred to as the father of EMD. And by the beard, I think that's very appropriate today. You do look like the father of EMD. He served as medical consultant for the hit television series Rescue 911 with Bill Shatner, and wrote the definitive textbook on the subject, Principles of Emergency Medical Dispatch. He's an emergency physician, has held the position of fire surgeon, medical director for Salt Lake City Fire Department, fire surgeon, medical advisor for Salt Lake County Fire Department, and also medical director for Gold Cross Ambulance Service. So he's crossed all the spectrums. He's been a provider, he's been in the field, and he's been a true leader. A past faculty member of the medical director's course in the National Association of EMS Physicians, and that's important to train them. He was chairman of the ASTM task force for the development of the National Standard for Medical Practice, and he co-founded the International Academies of Emergency Dispatch in 1988, that now has 56,000 certified members in 43 different countries. My God. Jerry Overton serves as the president of the International Academies of Emergency Dispatch, the organization charged with setting the standards, establishing the curriculum, conducting research for public safety dispatch worldwide. In addition, he's a member of its board of trustees and chairs its institutional review board. He previously served as chief executive officer of Richmond Ambulance Authority. And Jerry, I'll probably ask you, if you were back there, what would be the #1 concern on your mind? So I'll give you a little bit of time to think about that, because there's a big wide open one. Did that for 18 years, also served as chief executive of Kansas City, Missouri EMS system. He provides technical assistance throughout North America, Europe, Asia, Africa, including the design of a plan for emergency medical transport program in central Bosnia for Herzegovina, if I pronounced that right, actually during the war. So my hat's off to you. More recently, he was involved in upgrading the EMS system in the country of Lebanon. Past president of AAA, he was a member of the Institute of Medicine's Committee on the Future of Emergency Care in the U.S. Health System, and was the chief financial officer for the World Association of Disaster and Emergency Medicine, WADM. He serves on the editorial board of GEMS and was named one of the 20 most influential leaders in EMS by GEMS magazine, by a totally independent review committee. And he's received so many life achievement awards that I'm not going to even go there. Greg Scott has served as the Associate Director for Protocol Evaluation and a researcher with International Academy of Emergency Dispatch. And he's going to lead us off today talking about that. His career in EMS has included roles in EMS and fire responder, emergency medical dispatcher, dispatch supervisor, training officer, and 911 consultant. So that's pretty important when somebody is in charge of the protocol side of the shop. He's led numerous implementation of EMD programs at 911 centers across North America. He's also a emergency medical dispatch quality improvement instructor and member of the Council of Standards, and chairs the very important Chemical, Biological, Radiological, and Nuclear Committee. Brian Dale was retired as fire chief for Salt Lake City Fire Department after 30 years in the fire service, and took on the role of Associate Medical Director, Quality Processes for the Academy. He ensures that all dispatch protocols endorsed by IE&D meet or exceed all of those particular standards. And then last but certainly not least is Chris Iolak. Am I right, Chris? Am I getting close? Alola. And he's responsible for biomedical informatics with the Academy. Been there since 2006. So understanding that this thing is something that we thought could happen, but never really realized that it was going to happen until 100 years after the 1917 plague. Let me call on Greg and talk about Protocol 36.
Okay, thank you, AJ. So as chair of the CBRN group, and I'll just refer to it as CBRN because it's quite a mouthful, as AJ mentioned, our job is to review and update the pandemic protocols within the medical priority dispatch system, and to make changes quickly when necessary to respond to a emerging disease like COVID-19, such as the situation we're in now. So just as a starting point for Protocol 36, we decided some time ago that during a pandemic, dispatch agencies need a robust triage tool when the system becomes stressed, from high call load, workforce degradation, and hospital saturation, or all three, as is kind of the case right now in a few places like New York City. And that tool needs to be scalable at the local level, so it can be escalated and de-escalated at the direction of the local EMS authorities. And so the real goal of Protocol 36 is that EMDs can identify at the point of call intake, right at 911, those patients that are most likely COVID-19 symptomatic right now, and triage them with a single dispatch protocol that allows for the most efficient and effective use of the limited EMS resources that would likely are likely going to be available only sporadically or in a limited way during a pandemic. So it was used by some centers in the H1N1 flu outbreak, which some of you might remember back in 2009, 2010. We sort of, that was sort of the first time it was rolled out, and we know of a few centers that used it back then, and we kind of refined it along the way, got a little bit of data from the centers that were using it then, and then when COVID-19 hit, we had a tool that was kind of basically in place, but it needed to be refined to be specific, be a little more specific to the actual COVID-19 disease. So the idea of Protocol 36 is that we get, as I said, you want to get all your most likely COVID-19 cases in one place on one protocol, and then let that one protocol kind of triage things out from there in a very specific way. And so we're recommending, in general, we recommend that you start with 3 protocols that you would normally use under normal operations. So if the dispatcher, the EMD would normally use protocol 6, which is breathing problems, protocol 10, chest pain, and protocol 26, which is sick person, that all of those would then be put into the protocol 36 bucket and triaged from there. And that constitutes about 1/3 of all your cases. So again, the idea is you take those 3 protocols, that's where most of your COVID-19 positive patients are gonna be, especially the symptomatic ones. And you use protocol 36 to triage it out from there. And we'll get into some more detail on that. I think Dr. Clausen will get into some more detail on that. But that's the basic concept. And we've got a lot of agencies using it now with the existing COVID-19 outbreak. Thanks.
Jeff, I'm going to call on you to actually talk about some of the tools that now come into play, because I know that there's certain things and triggers, and there's, you know, things that I want you to hit on that ramp this thing up. So take it from there.
You bet. To add to what Greg was saying, and to sort of go back a little bit in time to the beginning of when we're hearing that things are coming out, usually of a different part of the world, our antenna is up, and everyone wants to know if those diseases and the patients carrying them are entering their system. So we have a process and a tool that's called the Emerging Infectious Disease Surveillance Tool, EIDS, and it functions as basically an adjunct to any protocol that you might be on that you think the patient could potentially be one that you want to evaluate. And it looks at travel history. It looks at, initially in a surveillance mode, it's a special setting for the tool, where it's looking for anything that might give us information that that patient may have, in this case, COVID. The tool is used then, and it's used also as a warning, because if we find anything that we think may represent a potential infectious patient, we want to alert the crews. As that starts to determine that there are more and more patients, and similar to what's happened in the last month, we've gone for no longer looking for them, but knowing they are out there and potentially starting to overwhelm the public safety systems. Usually, in this case, the hospital system and the EMS system that must transport them. The tool then, once we're not concerned anymore with finding the occasional patient, we change its setting to be what's called trigger mode. And in the trigger mode, the tool is no longer looking for history and places you might have traveled, people you might have been exposed to. It's looking really to see if you have enough primary symptoms of the infectious disease that's emerging. COVID now, it was previously Ebola for that H1N1. We actually used a precursor of the EIDS tool during the SARS, was developed for SARS. The trigger mode, once you get a couple of symptoms or hits, then notifies the dispatcher you have enough to tell the responders, and that goes out through an urgent message process in the automated MPDS system called ProQA, and notifies the CAD system to notify the MDT or MDC in the vehicle that this person shows evidence, be prepared to deal with that patient. It also indicates if there is minor evidence, but not enough to be conclusive, because we still want to warn them, to always be on your guard. We say that everybody uses universal safety precautions, but we know sometimes we use more caution than others at other times. And then we'd indicate if the tool found nothing, that then they're on their own, practice due vigilance, watching what you're doing. That tool becomes of less use in terms of diagnostic value and more to just identify the potential of infection for the responders. And P36 comes into main use at that point, and then starts to triage the patients, in which there's a series of settings in ProQA's administration utility, where we go from the default setting or level 0 to level 1, 2, and 3, in which we can then, per each dispatch code, assign a different level of response, a limited level of response, and potentially no level of response, and referral into a emergency communications nurse system or into some public health process then that helps to define the best place for the person to go or not to go or to stay in self-quarantine. So that's kind of the overview of the spectrum of how it moves through, to the point where at level 3, you'd probably be so overwhelmed that we call it dispatch Armageddon. So we haven't been there yet, and we hope we don't get there.
I'm sorry, I muted myself. My wife would love to have that button, I'm sure.
There you go.
I wanted to ask, where does things like weight and obesity, and are you a healthcare provider, where do they come into the protocol?
Well, in the EADS tool itself, there is the ability for the local medical directors to add other more specific local questions that may be deemed necessary to perform the task at hand, and also any special instructions that they can add that then show up in that particular tool. We may be looking for those, we look for high-risk patients in the protocol 36, and there's a definition of what they are, and it has to do with probably the most primary one is the age of the patient, where we know that as opposed to other diseases, this one gets is less worse in the young and much more lethal as we get older. People running around my age and your age.
Thank you.
Jerry's age.
So
running may be a bit of an overstatement there, Doc, but
now, Brian, I see you almost like the angel on the shoulder, because you've got so much field experience that
yeah,
as this thing is changing, has your role been to make sure that that protocol is really consistently looking at the field providers?
you know, it's interesting. The protocol itself, all of our protocols, including CPR, Protocol 36, the EIDS tool, we've added the automatic launch of the EIDS tool to more of our protocol types. It's literally changing day by day. Literally last week, after American Heart came out with the resuscitation standard for covering the mouth, we had to adapt to that. Our software won't come out until second week in May, but we've already put out a statement this morning about covering the mouth of a patient with suspected COVID with a light cloth or a towel to prevent the aerosolization of, during compressions. So we are literally meeting with Dr. Clausen and our rules group weekly. Every Wednesday at 2 o'clock, we're sitting down, going over what is going on, what needs to change. We actually started a Facebook site just for dispatching in the COVID environment, so they can get up-to-date information on what's happening, what we're doing, any documents that we have. We put out 2 different statements on CPR people, so we shouldn't be doing mouth-to-mouth on anybody. All of those kind of things we have to address. We have to address also people wanting us to add things to the tool, like the loss of taste as a potential, early sign. And anybody with a fever could lose some of their taste sensation also. So it's like we have to compare what people are saying and maybe talking about versus what we're actually seeing in the science. So we have to weigh those options. Medical directors can add certain things to the IDS tool. We're trying to manage those things as they happen. And the other thing Dr. Clausen's already mentioned, also we give the agencies the ability to start altering what they send. It's important for everybody to realize that if you reach a peak and it goes south and you get to this dispatcher Armageddon, then you have a lot more people calling in for things they don't normally call for. And you have potentially less dispatchers and potentially less responders. So these things, cook together to bring where you've got to make the most. Hospitals are deciding who gets a ventilator. And EMS, we may be deciding who gets an initial response or a response at all. And if we have limited ALS units, who gets those? So all of these things come down, and the tool is going to help agencies manage that. Once Dr. Clausen talked about those levels. Once it's turned on, it doesn't matter which chief complaint protocol you use, those levels of response will come up. So if you change the response, you're going to change it across the board, or you potentially could change it, the agency's decision. The other thing I want the responders to hear and to remember is that some agencies are launching the EIDS tool on every single call. Other agencies are launching it on only those things where they have flu-like symptoms. There are police departments that are using our EIDS tool as well, because we're seeing officers, or primary goal, not PPE, right? They're trying to provide them with better inbound information. Most agencies, or a number of agencies, are having them meet the officer outside, so the officer's not in that environment where they're touching things as well. And again, we're changing these things, we're monitoring them day to day. But the responders have got to realize sometimes the callers will tell us they've got no symptoms, and you walk in the door and it's not what we didn't not ask. The person decided that they just gave us the information, and we can only act on the information that we're given. So I remember back when we had the HIV/AIDS when I was in the street as a medic, and the only time I really got exposed, we asked the gentleman face to face, could you have a bloodborne disease pathogen? He said, no. And he bled all over us from 2 open fractures, and we get a call at 1 o'clock in the morning, the person was full-blown AIDS, untreated. So again, use your caution, use your best judgment. A lot of agencies are sending in one person in full PPE gown, mask, the whole bit, do the assessment, bring the patient outside. All of those things at the medical director and the agency's discretion. But, the system is not perfect. If garbage in, garbage out. If the caller gives us bad information, we only have so much we can do because we can't see the patient, nor can we see the scene.
Plus, all of a sudden, the experts come back and tell us that a lot of the patients that they're seeing are asymptomatic. So they're not necessarily going to trigger a bunch of things.
Correct.
So those things all considered, I'm gonna come back over to you, Chris, because as the person really on the biomedical informatics, I've seen some of the charts and some of the reports. That's really your forte. So what are we seeing out there? What do the reports look like?
Yeah, just a few things that I wanted to share. Thanks, AJ. Before I share the numbers, I think it's important for me to mention that these numbers are based only on data that we receive from the agencies that are sharing their data with the academy to support our research. So it's not the entire pool of agencies that we serve. So right now we have about close to 60 agencies that are sharing data with us, out of which we have almost close to 6.7 million cases, medical cases. What I've seen of late is, although the agencies are using the EIDS tool, as Brian has mentioned, we've seen an increased use of Protocol 36 as well. In fact, out of those 60 agencies, 27 of them have actually launched the tool on Protocol 36. And that shows us that at least apart from the EIDS tool, we're going to the Protocol 36 to make more determination of potential COVID-19 cases. The other thing that we see is that although they're going to Protocol 36, there are also a few of them that are shunting back to certain protocols like breathing problems, chest pain, or sick person. The percentage is low, but there are a few of them that is under 2% of them who are shunting back to other protocols other than 36. But all in all, the agencies are using a lot of these analytics that we're generating right now to make decisions at the agency level to modify policies on how to respond and things like that. And that has been a tremendous interest that they've developed in these analytics that the academy is able to provide them with. So most agencies are kind of developing their policies based on the evidence they're seeing from the data that we generate from them. And that's an encouragement to the academy to proceed to serve them even better.
Is there one particular symptom that seems to be triggering or coming up the most, like the cough or respiratory distress?
So what's interesting, if I could just add a couple of things to what Chris was saying, is that the tool, by the way, the tool is designed to do what's called a shunt if it doesn't find anything that looks like COVID-19. So in other words, if your, say your chief complaint was difficulty breathing, but if it doesn't find anything else that looks like COVID-19, it'll put you back on the original chief complaint that you would normally, under standard operating procedures, normally have, which would be breathing problems. So it's designed to kind of look for the COVID-19 specific symptoms, and if it doesn't find one of those things, it'll take you back. And as Chris said, what was interesting about some of the data we're looking at, it was less than 2% of the time we were seeing dispatchers shunt back to another protocol from protocol 36. So that tends to indicate that they're finding what we kind of thought they might find, that is these COVID-19 symptoms other than just the primary complaint. And if you look at, for example, the number one determinant code is the 36 alpha 3, which is a flu-like symptoms only. So again, that would suggest, and that was like almost a quarter of the cases. So that would suggest that that protocol 36 actually is doing what we kind of anticipated it would do. It would find those cases where you're most likely COVID-19 patients, because they are having these flu-like symptoms. They are symptomatic right now. Obviously, we're not going to find the asymptomatic ones on 36 most likely, but at least it looks like the tool's doing what we had designed it to do.
Well, the other thing, and Jerry, I'm going to call on you, is probably in your whole career, you never thought you'd see us in a situation like this, but I knew that call volume would decrease because that's what happens in things like this, and people are afraid to go to the site of where maybe the most infection is, but I never thought that it would get into the 20s or 30s. Could you address that?
No, I agree, AJ, but before I answer you, I'd like to congratulate you on receiving the James O. Page Award last month and at EMS Today. That was incredibly well-deserved. The second thing I'd like to say is thank you for actually doing a telecast like this that emphasizes dispatch and call taking, because you were right when you introduced us. Most of the time, you know, call taking and dispatchers, they're kind of the silent people that really aren't out there. They're not visible. And so I want to thank you for the emphasis on call taking and dispatch. On behalf of the Academy and PDC, I really, really appreciate you doing this. And to answer your question, no, I actually never expected a time. I know of at least 3 different surveys and scientific studies that are going on right now looking at exactly what you're asking. And even though the data is preliminary and anecdotal, at this point in time, we're seeing between a 27 and 32% decrease in call volume outside of COVID-19, 27 to 32% decrease in call volume in EMS systems internationally in all 3 surveys. And that's 911 and 999 calls. When we look at interfacility transports right now, systems are seeing a between a 40 to 70% decrease in interfacility transports. So excluding COVID-19, we're seeing a market decrease right now in what's going on in the activity of EMS systems. And that's going to, have some long-term ramifications on EMS system design because of the fact that the way EMS is funded, you know, whether we're looking at funding through Medicare and Medicaid on a per transport basis, because that means the transports aren't there, or, you know, systems that are receiving public funding, because local government budgets aren't going to be, or they're going to be very, very stretched. You know, just today, the city of Los Angeles, the mayor said that they're under attack from financing. The state of Massachusetts today said that, in fact, they're in a free fall from tax revenues. And this is going to impact what we're doing. And so, you know, I think when we're looking at system redesign tools like our emergency communication nurse system, in which we're going to be using ECNS, and systems we're going to be using and implementing ECNS more and more and more to look at how we can look at lower acuity calls, how we can provide a alternative for patients calling 911, 999, 000. ET3, which is, the HHS is right now soliciting proposals. That's a little bit delayed now because of COVID-19. I think we're going to see some major system redesign going on because of what we're experiencing right now is going to impact the long-term future of EMS.
And a couple things happened, like I know North Shore and Wasco and a few other people ramped up their nurse triage quicker. And I don't think we're ever going to go back. I think that those systems, some of them that went into this, are going to continue to use that forever. I know every doctor's appointment that I've had in the last 2 months has been virtual, and I love it. And I hope it doesn't change. And if they can keep getting funded for it, that's the better way to go than me driving all the way to the doctor and sitting for 20 minutes waiting for a 10-minute talk.
No, you're absolutely right. And North Shore is a great example of that. You mentioned Jonathan Weshko and the leadership he's providing in many different ways. That healthcare system is far in advance in looking at chronic patients and looking at 911 patients using telemedicine. And again, in fact, that's an accredited center of excellence for ECNS and MPDS. So they've really got it together at North Shore and what they're doing. But it's really interesting because of the fact that there was a couple of articles in the paper yesterday from the United Kingdom, and it's really in that critical care beds are not being filled right now by MI patients or stroke patients. They're empty. So where are those patients? And that's why ECNS and nurse advice systems are going to be so important in the future for interfacing with EMS systems. And again, we're ready to go with that when they are.
So systems that think that this is going to, after the pandemic's gone, we're going to go back to pre-pandemic, that's just not good planning. I really don't think that's going to happen. Do you guys?
No, I don't.
Probably not.
AJ, one of the things you talk about the tools, one of the things that we have done with this COVID is we have produced an online self-assessment specific to COVID for EMS. So the EMS provider would have this launch it from their website and then try to push the worried well, anyone who thinks they may have it, into this online assessment. And then they go through the assessment, which can consist of 6 to 7 or 8 questions based on the direction, the answers that they give. And then it has 10 different dispositions or endpoints at the end where they, have them, everything from call 911 right now to schedule a telephone or video call with your physician, to watch yourself, quarantine. We also give links or websites. They can do some self-education. The agencies can also add in their own URLs or phone numbers or whatever they want to that system. And then based on the disposition, the system would then send them a text to a secondary assessment. If it's a 911 call, like 4 to 6 hours later, if it's the typical worried well, 2 days later. So we are developing additional tools, and not just for COVID, we're now developing them for hurricane season, tornadoes, where the 911 centers, instead of hopefully getting inundated, we're trying to give them other tools or ancillary tools where they can manage those small crises or large crises with their own system and taking some of the calls out of the 911 system.
So we're not going to have this under control for quite a while, no matter what anybody tells us.
Right.
And, this past weekend, Jacksonville opened up their beaches. It'll be interesting to see what happens to their numbers 7 days from now, after we had thousands of people mingling with the air floating around there. And what do you think is going to happen 7 days after the first college football game where there's 110,000 people crammed into a stadium?
Just when you thought it was safe to go back in the water, AJ. That's what's gonna happen.
Yeah, I don't think that people really can appreciate that. I know we have to get the country started again. I'm all for that. But this is where the role of surveillance and first watch and all of that kind of stuff comes in, where we can start to see clusters. I've been talking to people about, are you going to let your cell phone be notified if you were standing next to Jerry and Jerry came down positive, and 7 days later you want to be notified on your phone. And it's amazing. Some people are like, no, they're never gonna know where I'm at. Well, it's
Nope.
not that they care where you're at. They just want to be able to notify you that you were exposed. That's
Right.
one of the only ways. Jerry, in other countries, are they using surveillance software?
Yeah, I mean, there is surveillance process in other countries, but I really don't think it's sophisticated like First Watch is, because most surveillance in other countries is more public health oriented and it's not real time. And so in other words, First Watch is designed to be real time. Interestingly, I was the first user of First Watch when I was the chief executive in Richmond. So I never envisioned when I implemented Richmond that it would ever be for something like this. We did it for like heat, or in fact, back then it was for anthrax. But the difference here is that First Watch is real time based on MPDS determinants. Surveillance in other countries is not real time. So in other words, they're gathering data and putting that data into some type of a program, a software program. So there may be a lag of a day or 2 days or even 3 days before you get the clustering that you're talking about. So we are thanks to First Watch, we were actually, and thanks to MPDS, because MPDS drives First Watch in these real-time situations, we're really ahead of the curve.
Well, one of the things,
Go ahead.
one thing that Jerry is alluding to that I think is often missed is that because the Academy is worldwide and has a unified protocol, dispatch codes and what they represent are identical everywhere. So if you're taking and merging information, that is not necessary then to determine if you're trying to compare apples to oranges to pomegranates. In essence, the code is the code is the code. The dispatch code is like an ICD-9 code or a barcode on a cereal box. It says that's what's in the box. What you end up paying for it is how you decide you're going to respond to that particular code. And everybody can do whatever they want. You can send a helicopter to a cat bite if you want to be that stupid. But it gives you the opportunity then to merge this data. And as Chris was saying, you could no more merge data coming from disparate systems than fly to the moon. You know, in other places, if you do that, then you've got, again, the apples to the oranges, where we've got an exact match of all the codes that are coming from 43 countries in 27 languages, in 3,000 plus centers.
So Jerry, I'm sorry, Jerry, you deal with a lot of the internationals, and those that aren't as sophisticated, are they looking to Chris and other people for data trends that perhaps might apply in their country because their data lags?
I'll let Chris answer that, but we're getting more and more requests. We're keeping Chris busier and busier and busier, I think. Right, Chris?
That's very true, Jerry. In fact, since December last year, we've been spending almost 50% of our time responding to requests from agencies all over the world. And as Jerry said, when it's out there, he's always sending us emails. Can we get this? Can we get that? Everybody's looking for evidence, and they want to base their policies on evidence. So the Academy has been very busy generating evidence for them. And this is why we came up with these tools that provide them with the analytics that they need to not only to monitor the trends, but also to make decisions that are helping them at the agency levels. So there's an increased demand for analytics than ever before.
Oh, God bless you. That's great. Brian, you had a comment. I cut you off. I'm sorry.
No, you're okay. Going back to your original question, I'm assuming you're talking about the Bluetooth tracking system for the COVID from the cell
That as
phone.
well, yes.
So one of the things I think would be very powerful, but I'm afraid that the very people that should be using it are not going to. But I think it has the power to really show those clusters and get those notifications back that I may have been close to somebody who is now exhibiting symptoms of the COVID virus. I think it would be phenomenal, but there's so many people that are fearful of, the big brother, the big government, that I don't think it will be as impactful as it probably could be, but it would be a phenomenal thing if it was something they couldn't turn off.
Well, I spent time the other day on a great interview with Dr. Katz down in Hollywood, Florida, and they have developed a nice system with their nursing homes. And I'd like you guys to address a little bit how the protocol and how the system picks up on the nursing home call, because that seems to be a very hot cluster right now.
Yep.
Anybody want to take it?
I'll
One of the
jump in,
things,
or
go ahead, Doc.
I think one of the issues is obviously the nursing homes are a concentrated group of people with high risk. So we're looking for high risk patients, and that is actually done on Protocol 36. If you look at that particular set of questions, there is a determinant for high risk, and in the data that Dr. Alola has compiled, we see that 36C5 is the second highest group with almost 24% of all calls that utilize CART 36. The high risk conditions go from young people under age 5 to over age 65, blood disorders, diabetes, kidney, liver diseases and disorders, neurological diseases, pregnancy, sickle cell disease, weakened immune systems such as AIDS, cancer, chronic steroid use. So that's a particular group that will benefit by actually being run through a protocol. There's probably going to be some difficulties in getting the information though, because the nursing homes at times don't provide enough information, given that the front desk is the place that's calling,
Right.
not necessarily the care provider who may or may not be there, or may or may not be in the facility even. So in essence, you're only as good as the information you can get.
I wonder if that'll change a little bit, because the caregivers know that they themselves are at risk. It's a little different than somebody who they think is sepsis and they're not going to catch the sepsis, but with COVID, they have the high potential. So, but I guess, if they're protected, they're protected. And if not, what's the response going to do for them? But, they just yesterday said that nursing facilities must notify the health system that they have somebody who's had COVID. Now, that doesn't mean that data gets entered into the dispatch center, that that you're going back on a call that you were there 2 days for. And as Dr. Katz told me, when they first got an alert that they had somebody that was positive, they went and they began to check out the nursing facility. And then they found out the next day that the second patient they received was the roommate to the first patient. So that's how data could really help you out and start to see clusters within a nursing facility. We're really going to have to tackle that.
We've also added that nursing home under living conditions to that online CAT tool, along with the BMI piece. Those are both added as high risk or higher risk patients for the virus.
Now, I don't know the answer to this, but Jerry, maybe you can tell me, is in CAD systems, do they have the capability of knowing that the patient they're responding to has 4 comorbid problems? Do they have that sophistication? No.
No.
There have been over time external companies that have tried to coalesce that information and make it available to now through apps and different things, but it's been not widely used. If it is, they're competing groups in different systems, so that there's not really an overlying thing. I mean, you have to enter it into CAD first.
Yeah, AJ, I will say this, our ECNS system does.
Yes.
If a caller is actually transferred to our nurse advice, to the emergency communication nurse system, we absolutely have the capability of having those 4 conditions logged into that ECNS system, and then it can be communicated. So our software in ECNS absolutely has the capability of capturing that.
And once you capture it, does it stay in the system as long as I'm alive?
Yeah, I think so. I mean, our ECNS system has a capability of capturing patient history and matching that patient back if that patient calls the second, third, fourth, fifth time.
Exactly right.
So can anyone go to the website and take a look at Protocol 36? Is it up there?
Yes.
Yeah.
So those of you
Yes.
that are listening here today, I'd really recommend that you go and take a look at it, because you really, in summation of our talk here today, number one, I want to thank each of you for participating. Number two, I want to really bless all of the dispatchers that are out there. And on behalf of the EMS community, thank them for being our first responders, because I know when I was a part-time street paramedic on weekends and things, Allentown's dispatchers every 5 minutes would call me and ask me if I was okay. And I've never forgotten that, because when I was in a tenement or somewhere and carrying an oxygen bottle, it might be my defensive weapon, to hear every 5 minutes, 72, are you okay? That was just a blessing. And knowing that you're responding, and I saw that one example call in chart 10, I think it was, that had all of the levels that the responding crews were going to know about. That's a lifesaver, because you're not going to go into a scene, or if you see a police officer walking in, and that's the other message for EMS units. If you get an MPDS report that you're responding on a call like this, you have to make sure that the comm center, many times located different from police, have notified police and fire, because they may walk into a totally unsuspecting coughing patient. And so, yeah, the world is going to be different. I'm not sure that EMS crews are going to let the family in an elevator with them anymore, coming down, 15 stories. I think that day is gone. I think riding in the ambulance is gone. So, we'll just see. The most important thing that I really gleaned in discussing with some of you is the fact that this is an evolving process, and God bless you that it's been evolving. And the other people that nobody even realizes is that, how many different languages do they have to translate this to?
I think it's 26 now, moving to 27.
26, 27 different languages. And that means that when a protocol changes, we got to get that out to the people almost like the next day. So your staff is working almost 24/7 to get this done. So again, thank you all, and keep up the good work. And any one of you with gray hair and maybe with no hair, well, maybe it's all of us, stay inside. You're the only Jeff Clausen that we've got. Remember that. Okay. Thank you all very much.
Thanks, AJ.
Yeah.
You.
Thanks.
Bye now.
Bye.